Welcome everyone, this is the first podcast in a series of 2 podcasts that we are producing for the EHA on CTCL. First I'd like to introduce myself. My name is Maarten Vermeer. I'm the head of the Department of Dermatology at the Leiden University Medical Center. And together with me is my co-host.
Hi, I'm Erik Marijt. I'm a hematologist in the Department of Hematology of the Leiden University Medical Center. And my expertise is allogeneic stem cell transplantation for hematological malignancies.
As I just said, this is the first podcast in a 2-part series discussing cutaneous T cell lymphomas, from how to diagnose, through how to treat, and finally how to manage complex presentations of this disease. In this first podcast, we will be concentrating on how CTCL typically present, are being diagnosed, and the top line in care management.
So, Maarten, to start, what are CTCLs exactly? Can you describe us their features?
Well, yes, of course. This is a group of rare T cell lymphomas that primarily present in the skin. Global incidence of CTCL is less than 10 per 100,000 per year, so it's quite a rare disease. And I should stress here that it is a rare collection of diseases. They all have a heterogeneous clinical presentation, a histological picture, reaction to therapy, and clinical course. The clinical course of CTCL often differs from histologically identical nodal counterparts, and for that reason specific classifications have been made for CTCL. One striking example is anaplastic large cell lymphoma, that if it presents in skin without extracutaneous spread, has a much better prognosis than their nodal counterpart.
Right, thanks. So what kind of subtypes do you have, and what are the most common subtypes, and what is the cell of origin of these diseases?
Yeah, the cell of origin in CTCL is typically a CD4 positive T cell and with a memory phenotype, and a number of cutaneous T cell lymphomas. These are thought to be Th2 cells, although I must say this has not been proven extensively and is still a matter of debate. As we already discussed briefly, it's a heterogeneous collection of diseases, and the different types of CTCL differ greatly in their clinical presentation and prognosis. The type of CTCL that is most abundant is mycosis fungoides, or I should better say it's the most common type of CTCL. It accounts for 60% of cutaneous T cell lymphomas and almost 50% of all primary cutaneous lymphomas. This is a chronic disease with a slow progressive course from patches to plaques to tumors, and eventually in a small minority of patients we also see localizations in lymph nodes or even other metastases. However, most patients only have skin localizations of their disease when they not only when they present but also during their disease course. The second most common group of cutaneous T cell lymphomas is the group of the CD30 positive lymphoproliferations. This encompasses on the one hand lymphomatoid papulosis. Those patients present with small papules and nodules that can ulcerate and then typically disappear within 6 weeks. And on the other hand, anaplastic large cell lymphomas. These patients present with large, often ulcerating tumors, typically localized on the trunk. A definite diagnosis within the group of CD30 positive lymphoproliferations is always made by integrating the clinical picture with the histology, because the same histological picture can be seen in both lymphomatoid papulosis and anaplastic large cell lymphoma. Both entities have a good prognosis, with extracutaneous localizations developing only in a minority of patients. The third group of CTCL is a group of rare and often very aggressive CTCL. These patients should be treated as a peripheral T cell lymphoma, despite the fact that at presentation disease is limited to the skin. I also should mention Sézary syndrome, which is a very rare type of CTCL in which tumor cells are found in the blood, skin and lymph node at presentation.
Okay, thanks. So how do patients with CTCL present at their primary physician or at your outpatient clinic? And is there a typical patient characteristic to be discerned?
Yeah, thank you. This is typically a disease of elderly people, and there's a slight male predominance. At first presentation, 50 to 60 years of age is typically patients with early stage disease, and elder patients might have more advanced stages of disease. And I must say, this is something that really applies to mycosis fungoides, which is, as I discussed earlier, a disease that sort of develops from patch to plaque to tumor stage disease. Depending on the type of CTCL, patients will have different skin symptoms. Patients with mycosis fungoides will have patches and plaques, nodules that might ulcerate, tumors, or even an erythroderma, which means a red skin from head to toe. This is different from patients with a primary cutaneous anaplastic large cell lymphoma that will present with solitary tumors or a number of tumors, and patients with a very aggressive type of CTCL, for instance, the CD8 positive aggressive epidermotropic T cell lymphoma, they might have a large number of plaques and ulcerating tumors that develop in a very short time. This all stresses the fact that the integration of your clinical picture with your histological picture is very important. So there is a large difference in mycosis fungoides in those patients that have early stage disease versus patients with a late stage disease. And late or advanced stage disease is defined as the presence of tumors and or erythroderma and even lymph node development and extranodal development and metastasis can develop in those patients. If we look at large registries, we see that in non-Caucasian patients sometimes present with more advanced disease and have a more rapid course of their disease, but this also might have their roots in the different socioeconomic background of different populations. And in some registries, we are seeing an overpresentation of hypopigmented mycosis fungoides, but this might also have to do with the skin type. The quality of life and also the prognosis of patients closely correlates with the stage of disease.
Okay, thank you. So sometimes patients progress with their disease and it becomes more aggressive. And can you explain to us what kind of factors are associated with this type of progression?
The first factor that's very important in determining the prognosis is, of course, the diagnosis itself. Then, within mycosis fungoides, which is, as I said, the largest group of patients with CTCL, there's the largest number of epidemiologic studies has been done, and always the question of which patients will progress and when is will they progress and what are the chances of progression have been studied most extensively. It turns out that increased age, elevated lactate dehydrogenase, male sex, large cell transformation are all associated with more advanced disease and a bigger chance of progression. But foremost, the disease type is the most important in determining the prognosis of a patient. So a patient with a Sézary syndrome will have a significant worse prognosis than a patient with a patch or plaque stage mycosis fungoides, for instance.
Okay, thanks. And I assume that advanced disease also has an impact on prognosis and survival.
Absolutely.
Okay.
So the moment we think or we know that we are dealing with more advanced disease, including lymph node involvement and metastasis, the whole therapeutic approach changes dramatically. But we'll talk about this later.
Yeah, thanks. So how is the clinical care for patients with cutaneous T cell lymphoma organized in your clinic?
Because the CTCL present in skin, often the diagnostic workup is done in close collaboration of the dermatology department and the pathology department. And at the dermatology department, we take a close look at the skin. We determine what type of skin lesions we are dealing with. And then, very important, we take a biopsy. We are in the position to easily take tissue samples to see under the microscope what's going on. We also always have a collaborative dermatopathology meeting where we take a look at these skin biopsies, and not only the morphology and the architecture of the infiltrate will be of interest, but also the close detailed immunophenotyping is paramount to make a correct diagnosis. Combined with the clinical picture, we can make a clinical pathological correlations and finally arrive at a correct diagnosis. And this is important, and because, as I discussed, lymphomatoid papulosis versus anaplastic large cell lymphoma, there this clinical pathological correlation is critical. Same holds true to make a diagnosis of mycosis fungoides versus anaplastic large cell lymphomas versus a peripheral T cell lymphoma. After we have arrived at the correct diagnosis, in some cases staging is necessary. This is not always the case, so a mycosis fungoides patch or plaque stage, no additional staging is needed. But for instance, in a patient with Sézary syndrome, you would definitely need a PET CT scan. And in anaplastic large cell lymphoma, you would also order a PET CT scan to know more about the stage of the disease and exclude nodal localizations. And bone marrow biopsies are no longer routinely performed at the moment.
And can you say something about the official staging system for cutaneous T cell lymphomas?
The official staging system that has been developed for cutaneous lymphomas also takes skin stage into account. So we do look at the extent of skin disease as well. And this is somewhat special, I should say. And for instance, in mycosis fungoides, we make a distinction between those patients that have patches and plaques, stage 1A and 1B, versus patients that have tumors, which is stage 2B. This is then combined with the N stage, the stage for nodes, for lymph nodes, extracutaneous metastasis, and blood stage.
Okay, thanks.
So after, let's assume that the staging procedures did not detect any extracutaneous involvement, so we are really dealing with a primary cutaneous T cell lymphoma. Then we have to decide on the type of treatment. This is for early stage disease, in sort of initial stages of the disease, so to say, we can revert to skin-directed therapies. So we are treating the skin, for instance, with local corticosteroids, and this should be the stronger steroids. An alternative would be, if there is extensive involvement, light therapy, such as PUVA. An alternative is bexarotene gel, this is a retinoid, or a chloromethin gel. And in all instances, patients are able to treat the skin lesions that they have with these ointments themselves. PUVA treatment is typically given twice a week. And then if there are more infiltrated lesions develop or frank tumors develop, radiotherapy is a very good way to treat these lesions. So in most mycosis fungoides patients, the disease can be controlled effectively with these skin-directed therapies. As you can imagine, the clinical care for CTCL patients is not provided by dermatologists alone. Far from it. From the beginning, we are a team. We work together with the pathologist, but also with the radiation oncologist and also with the hematologist, especially to decide on at what moment more advanced therapies are needed. And I have to advise my listeners here that at our second podcast in this series, we will be discussing the treatment options for more complex diseases in much more detail.
Okay, thanks. So when do you involve a hematologist to help you treat the patients?
This depends very much on the diagnosis, and for patients with a advanced CTCL, so Sézary syndrome, or patients with extensive tumors in mycosis fungoides, we would always want to discuss these patients with a hematologist to advise us on what type of systemic treatment we should start to use, and with what ID that treatment should be given. In patients with a very aggressive cutaneous T cell lymphoma, we should immediately discuss this patient with the hematologist. But in those patients with an early stage mycosis fungoides, this is not needed. We can treat those patients, as I said, with so-called skin-directed therapies.
Okay, thanks. Or did you want to add something more?
Well, maybe it's good to add to this that how this is organized. We, as specialists, as I said, we are working in a team, and with the pathology, we have these weekly meetings. We also have weekly meetings with the hematologist to discuss the patients that we think might now be eligible to systemic treatment with chemotherapy. And in addition to that, we have, of course, our weekly clinic where we see patients together that are already receiving this treatment or are considered to receive chemotherapy. And maybe in addition to that, we always try to organize our patients in such a way that if needed, we could come over and take a look at the skin, maybe take additional biopsies or if needed. So I really like to stress here that the combined clinics that we have are really important to give very well integrated patient care.
Yeah, and definitely also the radiation oncologist is always involved in those outpatient clinics.
Absolutely, I should have mentioned that immediately, but especially in mycosis fungoides, the radiation oncologist is extremely important to treat those patients that progress to tumors, and also ILCL that responds beautifully to radiation.
Yeah. So, in what way will new diagnostic methods help to improve patient care, and what kind of new diagnostic tools and techniques are available? Can you tell us something about that?
Yeah, I'll limit myself here to the advances that we are seeing in tools to quantify tumor cells in blood. These have much to do with the advances that have been made in Flowcytometry, and we are at this moment actively involved in a number of studies where we would like to get to a much better and more precise blood staging system that can detect and quantify tumor cells in blood. That would really help us in quantifying the blood stage for patients, and would also help us in those patients that we do treat with a stem cell transplantation to see if minimal residual disease is present, and also the emerging of novel blood clones could then be closely monitored. In addition to that, the studies that have been performed with especially next generation sequencing, have given a lot of insight in the genetic instability and all the genetic lesions that are found in these tumor cells. These studies have especially been performed in Sézary syndrome and are in lower numbers of studies have been performed in mycosis fungoides and ALCL. And many of these studies have identified novel activation pathways that are operative in these cells, including NF-kappa B pathway and the YAG-STAT pathway. The benefits of all these novel developments for the treating physician and for the patients in the foreseeable future are, I think, that in a few years we will be in a better position to quantify and monitor tumor cells, and hopefully also be in a better position to select patients for systemic therapies and stem cell transplantation. And in those patients that are being treated in these intensive treatment regimens, we can monitor tumor cells better than we can now. With that, I'd like to summarize. What I think are important points to take with you from this podcast are that cutaneous T cell lymphoma is a group of rare T cell lymphomas. They differ greatly in clinical presentation, histology, reaction to treatment, and prognosis. Diagnosis and treatment is performed in a team of dermatologist, pathologist, radiation oncologist, and hematologist. Depending on stage, we can use skin-directed therapies, and in more advanced cases, systemic treatments and or even a stem cell transplantation is the treatment of choice. And this will be discussed in more detail in our next podcast. So I really hope that you will come back and join us for the next one as well. And with that, I'd like to thank all the listeners for their attention.